Morning, all on the platform. Can those colleagues with nameless devices please name your devices? Thank you.
Recording in progress.
Good morning, honorable members. Good morning to the MECs as well as the delegation from the department and the support staff of the committee. Marcel, I just check, are we a quorum yet so that we can start?
Good morning, Chairperson. Good morning, colleagues. Chairperson, we are quorum. We may proceed. Thank you.
Thank you very much, Marcel. Honorable members, I just want to welcome you to this select committee meeting of social services and as well as the honorable MECs.
Sorry,
And
Comrade Chairperson. I'm
yes,
sorry,
Honorable
Chairperson.
Sibande.
Before we start,
Yeah.
I wanted to make an appeal to you so that you can correct these people. They must rename their gadgets or else take them out now. We mustn't waste time. There is two cell phones. The other one is written 1930750. There's no name. We don't know who's that person. The other one is T iPhone. These two people, they must rename their phone or else take them out, please.
Thank you, Honorable Sibande. I will request the participants in the meeting that did not rename their phones. Can you please rename your phone so that we as the committee can be sure who we are dealing with? So, and I will request the staff to help in that process. So I just want to welcome the honorable MECs as well as the...
Sorry, ma'am. There is another one, which the edit one, the third one, is 293922229. No, please, ma'am. There are three now, ne?
Yeah.
We can't go ahead with these people because we don't know whom we are dealing with.
Now it's fine, Honorable Sibande. I have just requested them to rename their gadgets. So I will give them 5 minutes, Honorable Sibande, before we proceed with the meeting.
Thank you, Chairperson.
If the participants have any trouble to rename their gadgets, they can just shout out to the staff so that they can help them.
Namantu Nkomo Ralihuku MEC for Health in Gauteng, if I can be remained in full, because it's just indicating that Namantu's iPhone, so I would prefer, Madam, my names to be seen by you, especially.
Thank you, Honorable MEC. It's just that one of 1930750 that is still not renamed.
Morning, Chair, and morning, Honorable MEC and members on the call. That 1930750, it's Anele Aplin. I'm the CIO. I was just trying to change, but I will try to change it again. Thanks very much.
Thank you, Anele. So I will request the staff to please rename Anele's gadget.
Excuse me, Chair. Sorry, can you repeat the name for Anele?
Yes, it's that 1931, Anele.
Okay, thank you, Chair. Because there is an Anele in the meeting, so he's using two gadgets.
We will, Anele, can we get that clarity? Do you use two gadgets?
Yes, Chair, I was just trying to change my name on the other gadget, which I will remove it now so that I'm remaining with the one that has got my name in it.
Thank you, Anele. So then we can proceed with the meeting, Honorable Sibande. The other ones that is indicating iPhone, the name is after the iPhone.
Yes, ma'am. You are
All right.
correct. Yeah.
Thank you, Honorable Sibande. So I just want to welcome the honorable members, the honorable MECs, the delegation from the different departments, as well as our support staff to this select committee meeting of social services. Without wasting any time, honorable members, we will proceed to the agenda. Today we will receive the briefings from the provincial departments of health regarding the readiness to implement the health patient registration system and their action plans to address the findings of the Auditor-General. So, honorable members, it will be 3 provincial departments. The first one will be Gauteng, the second one Limpopo, and then Northwest. So, honorable members, can we first get a mover to adopt the agenda?
Honorable Sibande, I move
Thank
with the adoption of the agenda.
Thank you, Honorable Sibande. Any seconder?
Second, Honorable Mkweli.
Thank you, Honorable Mokwele. Thank you for the seconding of the agenda. So then we move to the apologies. Marcia, can we get the apologies?
Again, good morning, Chairperson, honorable members and colleagues. Chairperson, we received an apology from member Noble, who's currently off sick. And then we've received an apology from member Priet, who's currently in another committee meeting. Thank you, Chair. Ms. Baines also, Chair, sorry, Chairperson, Ms. Baines is having network issues. She's trying to connect on the road. Thank you, Chair.
Thank you very much, Marcel. So can I get a mover for the adoption of the apologies? Honorable Sibande,
I move for the adoption of the apologies.
Honorable Mokwele,
No, Chairperson, before I move, but I was Honorable Baines. I mean, he's inside the meeting, but I also move that we accept with the note Honorable Baines is in the meeting.
Chairperson, please note myself, Honorable Aris. Thank you.
Thank you, Honorable Aris. So thank you for seconding the apologies. So Honorable Baines is in the meeting. So I will request the different departments, because of time, we will allocate 30 minutes to each and every department to do their presentations. So we will start with the Provincial Department of Health of Gauteng. If the
Chairperson, I
MEC,
see the hand of, is it Makifane? I don't know whether.
I think it's a legacy and for the seconding of the apologies, Honorable Makwele. Is that right, Honorable Fanny?
You're correct, Chair. Yes, it's withdrawn now.
Thank you very much, Honorable Fanny. So we will move over to the MEC of Gauteng for the preliminary remarks from your side, and then you can give over to the HOD to do the presentation. Thank you very much, MEC. the MEC of Gauteng. If she's not in the meeting, we can start with the HOD to do the presentation.
Chair.
Yes, Honorable Makwele, I think.
No. Thanks very much, Chairperson. And greetings to honorable members and the official chair. I'm not overriding your ruling that in the absence of the MEC, the HOD may proceed. But as the select committee, we need to know the whereabouts of the MEC, whether she apologized or if it's he apologized or what is happening. Because remember, we have invited the department. We therefore wanted to know about the people with executive authority to tell us whether they are with us or not, so that we must not be seen that we have invited the official, not the department. So maybe can I get the sense of the whereabouts of the MEC of Gauteng? Thank you.
Thank you, Honorable Makwele. We did not receive an apology from her, but we will request the HOD to indicate to us if the MEC will be part of the meeting. HOD.
No, good morning, Chair, committee members and colleagues. Chair, the MEC has been called with myself to an agent meeting with the Cancer Alliance that's starting now 10 for half an hour. It was a standing meeting as part of the SOPA commitment on the Cancer Alliance issues, I think, that are known or may be known to the committee in terms of the ongoing litigation. So, Chair, if it's in order, I could do the introduction of the presentation and allow the CIO to take us through the technical report, by which, by the time the presentation is done and the CFO dealt with the audit issues that the committee has requested, will then be completed with that meeting, which is currently on, and then we can then engage with as far as the question and answers are concerned. If that's in order. If that's not okay, I'm happy to take the committee through the presentation to check.
HOD, my proposal is that we pause the Provincial Department of Gauteng and we will move over to Limpopo. So you will proceed with that meeting, and after the half an hour, you can join us then. Honorable members, is that fine with you?
It's
So
fine.
thanks so much. That'll be very much appreciated. Thanks a lot.
Thanks a lot, HOD. So to the MEC of Limpopo and the HOD. MEC, over to you.
Thanks very much, Honorable Chairperson, and greetings to yourself and all members of the House. Honorable Chairperson, let's take this opportunity and appreciate this meeting and allowing us to come here and present to you. And then I will then hand over to the acting HOD of the Limpopo Department of Health, Dr. Ndwamato, to take us through the report. Thank you.
Thank you, Honorable MEC, but I will request if you start to talk, can you please just switch on your video for a moment so that we as the committee can be sure it's the right MEC. Thank you very much, MEC.
Okay, thank you.
Thank
Thank
you,
you very
MEC.
much. Yes, Honorable Chair, it's me, MEC Teketseng Mashiro, MEC for Health in the Limpopo Province.
Thank you, MEC. Over to you, HOD.
Honorable Chair. Honorable
Yes.
Chairperson, we are requesting that the admin unmute the Limpopo Department of Health. They are unable to unmute.
Thank you very much. MEC, can the staff please unmute the Limpopo Department of Health gadget?
Sorry, Chairperson, can I just get a name for that person? Thank you.
The gadget is named Limpopo Department of Health.
Thank you, MEC. Marcel.
Good morning, honorable members. And Chair, I'm Dr. Ndomato, the acting HOD. With me, I'm having a team from my tutor as well as the CFO who will assist us in the presentation that is going to be made. So they are going to share the presentation and we'll start with the HPRS followed by the action plan with regard to GSA.
Chair, we can't hear properly. Maybe if you can come near to the mic, maybe something's not right.
Thank you, Honorable McQueen. Can you please move to the mic because we can't really hear you clearly.
Good morning, Chair and honorable members. Am I audible now?
Yes, you are.
Yes.
Okay, my name is Dr. Ntodeni Ndwamato. I'm the acting HOD. With me, I'm having my GTO as well as the CFO. We are going to present first the HPRS followed by the audit action plan. GTO will present the HPRS and then the CFO will present the audit action plan with regard to the 2024-25 findings. Thank you.
Thank you very much, honorable members, MEC of Department of Health. My name is Albedi Ravuruvuru. I'm going to take you through the presentation from Limpopo Department of Health. Okay, under the table of content, we're going to be looking at the two items that we've been requested to focus on. And as part of the background, the HPRS, which is the Health Patient Registration System, HPRS is an electronic system used in public facilities to register patients. And the registration requires an ID book. The system allocates a unique number for the patient, which will be used in the entire country whenever the patient visits any facility. The problems that we had before the system was developed is that we have manual registration, which was time consuming and error prone. The paper records are difficult to manage and prone to loss, lack of integration with other systems. We've got delays in patient care due to ineffective or inefficient data handling. And then to resolve these problems, National Department of Health has developed the HPRS system, which was subsequently then rolled out to the provinces. And under the implementation, we rolled out the project. I mean, the rollout of the project was done by NDOH, obviously together with the Limpopo Department of Health. And what is happening now is that NDOH technicians provided on-site support, on-site training, installation of the application as well. They manage the help desk. They also do the software updates and they manage the user accounts. So when the project was rolled out, NDOH procured set of hardware in all, and we provided this in all our PHC facilities in the province, which was at the average of around 4 to 5 computers per facility by then. And then LDOH have 476 PHC facilities as we speak now, and 40 hospitals. Actually, it's 41 hospitals with MDR. I think we just made an error there, is 41, not 40. And then the LDOH implemented HPRS as of 2014 September because one of our district was identified as the pilot site, which is Bembe district. To date, HPRS has been implemented in all facilities, and NDOH has not yet implemented HPRS at the hospital level. And this was due to the challenges that we as the province are having with the current health information system that we are utilizing, which is very old and cannot integrate with the HPRS, meaning that if we were to proceed now, it simply means that each hospital is going to sit with two systems that are not talking to each other. So when registration for single patient is done on HPRS, it will also be done on the PEs that we are utilizing at the hospital at the moment. Hence the delay to implement HPRS at the hospital level. The next one is also summarizing the following. The training was primarily focusing on the reception staff. These are the staff that are sitting where patients arrive at our facilities. Administration of the system is centralized currently at National Department of Health, which includes the version update, user management, as I've already indicated in the previous slides. LDOH does not have administrative rights to the system and logs calls when issues are experienced. It means that we'll have to currently wait for national as and when there are issues that we have reported to them, or when we have new users, we have to complete the form and send it to national to create the required or needed users. 185 facilities are currently operating on the older version, and 291 are on the current version, which is the new version. So by end of May 2025, 364 facilities were operating offline. That is the report that we have extracted from the one we got from National, which indicated that the balance of the facilities were not syncing the information that has been captured to National. And out of these, 7 of the facilities are not capturing due to non-functional computers. However, these 7, the province is busy assisting them to provide them with the alternative hardware that they will be utilizing at the moment. And then the offline mode is used for continuous registration of patients and capturing visit when connectivity to the central server is lost. Basically, what is happening here is that National has assisted the provinces to ensure that even if we can have a problem with connectivity or challenges between the local server and the central server, it should not necessarily disturb the work that is supposed to be done at a particular clinic. So meaning that you may find that, yes, the clinic is not syncing, but it does not necessarily mean that the work is not being done. Then this slide is indicating that as at end of May, comparing the population of each district to the patients that are already captured in the system. You'll see that Capricorn is having 1.3 population. We have already in our system captured 1.399, which is just below 1.4 million. Mopani is having 1.2. We have captured 1.8 million patients to date. Sikukune is having the population of 1.287. We have captured 1.2 million patients to date. Wembe is having 1.543. We have already captured 1.650. And Waterberg, lastly, is 796. We have captured 777. And in total is 6.2 for the province. We have captured 6.8. The reasons for some of these numbers that are not talking to each other is possibly, when we look at it, is possibly because of duplicates that may be there and the foreign nationals that we're assisting, because obviously they are not counted as part of our populations. Hence, other numbers will be more than the number that the district of the population of the particular district. So we're saying that this might be due to the issues of duplications and also the foreign nationals that we mostly assist in the Bembe district and also the Mopani district. The next slide is about the number of facilities that were online as of end of May, broken down in the districts, where we've got Capricorn 18 synced out of 101, Mopani synced 25 out of 104, Sikukune 18 out of 89, Bembe 30 out of 123, Waterberg 14 out of 59, and in total 105 synced by end of May out of 476. The challenges that we are experiencing is that due to the system being centralized or the administration of the system being centralized, it results in long turnaround times. And then the synchronization of the offline, which is the on-premise, and the online server. And the intervention or the solution to these two challenges is that National should then consider decentralizing the support of the system to provincial technicians so that when we have issues, our own technician will not have to wait for the assistance from national department, but they can be able to resolve issues as and when they happen. Then we've got the major one, which is the internet connectivity, particularly in our province, which is mostly rural. But how we intending to deal with this matter going forward is that we are planning to roll out the routers that are going to assist the facilities to connect to internet. But these routers, unlike the current standard, if I may call it that, standard Wi-Fi routers that we have provided, which we cannot manage, these routers can be managed centrally here in head office, where we can be able to check if the specific facility is having connectivity or not. Because currently we don't have any visibility. We have just provided, but as and when they do experience challenges, we cannot see it from the central location. The other challenge that we're having is the aging tools of trade, which are mostly the computers that National has provided when we started rolling out the project. They've already gone more than 5 years, and they need attention at the moment. But how we're going to address this as the department, we're going to look at how we can assist these facilities to refresh the current hardware that they are utilizing in their facilities. On the recommendation, some of the recommendations beside the solutions that we are planning to implement is on the connectivity. We're saying that the state-owned entities to be compelled to install broadband infrastructure in rural areas. NDOH to assist the province in sourcing fund to procure replacement computers. NDOH to also decentralize the support of the system, which I've already touched on. I will hand over to the CFO to take us through the AGSA findings and the audit action plan. Thank you, Chairperson.
Good morning, Honorable Chairperson, honorable members, as well as all the MECs on the platform, HODs and colleagues. My name is Justice Mudau, the CFO, Department of Health, Limpopo. I'm going to take you through the audit action plan and the progress that we have already realized at this point in time in terms of resolving the findings in order for us to get, the clean audit opinion. The first part that I'm going to talk about in summary, which is not part of the presentation, is that for the year 2024-25, 2023-24, we had 25 audit findings, and of which of those audit findings, the department has already successfully managed to implement 21, and they are left with 4 audit findings not yet resolved, which I'll also touch base on as to the reason behind why they are still outstanding. Looking at the 21 that we have already successfully implemented, the first one talks to the movable asset, wherein the finding was talking to non-compliance with Treasury Regulation 16A.77, wherein the department was found not having, approached any state institution when it disposed the computer-related equipment. And the root cause being that the assets that were sold and which were found to be obsolete, the department interpreted the requirement to be applicable only to equipment that is usable, that we can donate to education institution. I would like to indicate to the committee that we have already implemented that. At this point in time, we are awaiting for the provincial treasury to review what we have implemented, as well as the outcome of the current regulatory audit that is taking place. The second one is also talking to the movable asset, which is the asset recorded at zero value and not included in the asset register. The root cause being it was the late finalization of our fiscal verification, which resulted in asset picked up from the floor during the fiscal verification not being investigated. The department has already resolved this very same finding, and also we are waiting for a provincial treasury to review. The third one, it was the fraud and corruption issue, where in one of our tender, it was found that the insurance letter which was submitted by the bidder was not authentic, coming from the bank. The AGSA has recommended that we then refer this bid for investigation, of which at this point in time the investigation has been conducted, and we have also involved the subs, because we realize that this is a criminal case. Having implemented it 100%, we therefore wait for provincial treasury to review. The fourth one is the HR related matter, which talks to committed overtime paid to officials that were on maternity leave. And here the root cause was inadequate review and oversight by the management. At this point in time, we have already implemented 100% of it, and we are awaiting for the provincial treasury to review. And also under human resources, we also have the incorrect calculation of leave days utilization in processing the leave gratuity payment, resulting in an over or underpayment, which was as a result of inaccurate leave credit audit and inadequate compliance review regarding leave days. We have also 100% implemented that. And also under human resources, we also have the incorrect leave days used to calculate the leave provision, of which the very same root cause, like the one that I touched base on, is the same, which we also implemented 100%. Coming to issue of legal services, we had a finding which identified number stated in the files not verified in Home Affairs. This was referring to what we call the medical legal case register, which was the lack of oversight on our side. As a department, we've already implemented that. We are awaiting for the review by our provincial treasury. Also under legal services, on the very same, contingent register, medical legal, we had a finding which talks to field required in the case management system that are not completed in the contingent liability register, which we have also implemented 100%. Then we also had another one under human resources, which was talking to approval not obtained to perform remunerative work, which the root cause, it was non-adherence to requirement and circulars relating to application for approval of remunerative work outside the public service. We have also implemented 100% of that. Coming to the next one, which was now under finance expenditure management, it was the payment not made within 30 days. which the root cause was invoices submitted to the end users and not through the expenditure office, and late confirmation of receipt of goods, which talks to the goods received vouchers. We have also implemented that, and we have also implemented what we call consequence management to remedy the situation. On fruitless and wasteful expenditure, determination test not concluded and finalized within 30 days, wherein it was lack of oversight as a result of lack of capacity under the internal control unit, of which at this point in time we have added capacity and we are in a position to carry out the determination within 30 days. On departmental revenue, we had a finding which talks to late billing of services of the patients that have received the services at our hospitals, and this was lack of capacity from responsible officials as well as poor filing movement process, which we have also 100% implemented, and also services not billed at all, which was as a result of delay in reconciliation outreach patient accounts and lack of billing procedure for outreach patients, and also lack of oversight was one of the root cause. However, we have also implemented that. Then coming to the next one, which is just talking to the duplicate payments made to suppliers. Here it was negligence by processing officials due to ignoring the system warning, wherein BAS has indicated that this particular invoice exists on the system, but those officials, proceed in processing the very same invoice, and we took, a consequence management against those officials who were found wanting, and as a result, it has been 100% resolved. Also on the debtors and liabilities, the department wrote off the below debtors which they could have recovered the amount owed to the department from the leave gratuity payout made to the dependents of the deceased. This was as a result of negligence by officials processing the leave gratuity. At this point in time, this matter has been resolved 100%. Now coming to the information technology, this is where we started to have a bit of a challenge. If you look at number 1 and number 2, where we have managed to implement 60 to 90%, we are not yet at 100%, and the second one between 30% and below is as a result of the old systems that we have in Limpopo, wherein we are still busy with CETA in making sure that we replace the legacy system in order for us to be able to resolve these two particular issues. But going to information technology, which is line number 3, information and communication technology structure, was not fully capacitated. It was because of the budget constraints, and as a result, we have now provided the budget, hence we have managed to implement 100%. And on the last one, lack of ICT architectural policy as required by the Departmental Corporate Governance Information and Communication Technology Framework and Charter, we have also gone to an extent of implementing 100% of that. Continuing with the information technology, wherein we failed to implement 100% of the action plan, where we are below 30%, as well as the PEs, the two are still talking to the legacy system that is supposed to be replaced. And now coming to the last one, where we have managed to deal with 100% of the finding, it was the weaknesses in the physical and the environmental control measures in the ICT policy handbook, which were noted as the guideline did not address important aspects. We have also implemented 100% of that. Going to performance information or strategic operation, we have also managed to implement 100% of that, as well as limitation due to material differences identified between the DHIS, which is the District Health Information Management System, reconciliation and register during the data integrity check. We have also managed to address 100%. I thank you. Over to you, HOD.
Thank you, Honorable Chair, honorable members, and I hand over back to our Honorable MEC to close.
Thank you very much, Honorable Chairperson of the House, and that is the report that we have for the House, and we'll hand back over to Honorable Chair. Thank you.
Thank you, Honorable MEC and the team from the Department of Limpopo. We really appreciate your presentation. I saw the MEC of Gauteng is on the platform. MEC, we will proceed to the Gauteng Provincial Department of Health. So to do your preliminary remarks, over to you, MEC, and you can give over to the HOD for the presentation. Thank you very much, MEC. MEC of Gauteng. Honorable MEC of Gauteng. So we will move over to the MEC of Northwest. We will take the Gauteng Provincial Department last. MEC of Northwest.
Yes, Northwest. Northwest. Thank you very much. Thank you very much. My name is Jonas Lahari. I'm with some management here, led by Standing AG, Mr. Dibia, the CFO, Mr. Rampedi, Chief Director Corporate, Ms. Tohani. I don't see DDG. I don't see DDG. But I will proceed. Well, I will just do the overview, Chair, and from there I will hand over to the Standing DG to report. Thank you, Honorable Chair of the Selected Committee on Social Services in National Council of Provinces, and then also all members of the committee. Chair, as a province of Northwest, it is with such great humility that myself and Team Health, as we call ourselves, we appear before you today for this important briefing. Our appearance today comes right on the foot of the commemorative events across the country signifying the bravery of the youth of 1976, and indeed a turning point that heralded historical events that led the new democratic South Africa. Honorable members, as we meet today, we take leave from the commitment to the cause, as it were for the 1976 youth. For us today, Chairperson, we want to remain true to the cause of the delivery of healthcare services to the people of Northwest. Chairperson, this briefing by the Northwest Department of Health is to keep this honorable committee of our readiness to implement the health patient registration system and action plan to address the findings for the Auditor-General of South Africa. On implementation of the health patient registration system, honorable members, as the Northwest Province, we have carefully implemented this important system that enables us to know who, when, and for what a patient when seen by our nurses and doctors. In other ways, any person clinically attended to is reflected in the system. Now, I was speaking to myself. I should emphasize this because it is important. Our healthcare professionals were adequately trained on digital capturing of the information through ID numbers and names, facility names and dates, which makes it all easy for us to not only know the number of patients received, but also to monitor them for compliance in as far as medicine collection is concerned. Honorable members, the Northwest Province has registered 3.4 million patients on the HPRS to date, with follow-up visit to facilities of just about 10.5 million head count. These are encouraging numbers. On some challenges experienced during the process of implementation, honorable members and the House, like with any other digital service that is dependent on network connectivity, we are not without our own challenges as a province. HPRS system utilization monitor and chairperson. It is important to note that 101 out of 319 facilities are actively using the HPRS system. We are hindered by connectivity issues in some facilities, but we are soldiering on. Honorable members, this is as our province is predominantly rural, and some of these facilities in the far-flung rural areas are still experiencing this very challenge, but we are intervening as a province. Findings of the Auditor-General, Chairperson and members, fellow MECs, in as far as this matter of implementation and improving health patient registration system, we have been cooperating and working with the Office of the Auditor-General. This includes working on all recommendations by the Auditor-General's office to improve the system. As part of implementing recommendation of the AG, the department has developed a detailed action plan with clear goals, which I am encouraged that when fully implemented, the system will work effectively to better our delivery of health services in the province. As I conclude, Chair, honorable members, once more, thank you for making the time to bring us here before you. We also want to say we commit that everything discussed and recommended from this meeting that will help us improve and better our system will be looked into with a view to fully implement it. I will now, through the chairperson, to allow the stand-in SG, Mr. De Beer, and the team held to provide a fully detailed report as preluded by this overview. The SG is on leave. That's why we're having the acting SG, Mr. De Beer. So through the chair, I will now hand over to Mr. De Beer and the team. Thank you very much, Chair.
Thank you, Honorable MEC. Honorable MEC, I can hear your network is not stable, but I will request you just to put on your video for just a minute so the honorable members can see who is the Honorable MEC of Northwest.
Yeah,
Thank you very much.
let me move here also. I'm at Mafike. Also, I try to press. Let me shift here. But I'm in the meeting. Video. I'm still trying to press.
No, fine, Honorable MEC, but if you have.
Yeah, when it's ready, I'll press it because of I don't know what is happening, but it's the network. Even now, I try to mute. It can't.
No, thank you, MEC. So we will move over to the acting HOD.
That's not.
Thank you, Honorable Chairperson, honorable members, honorable MECs in the meeting. As indicated, I am Yanni Ribeer, responsible for strategy and systems, but I will be also standing in as SG for today for this purpose of presenting this presentation.
Acting
So the
HOD,
outline.
there's really some commotion in the background, so we can't hear you clearly.
Can the committee or the administrator just mute the other parties?
You can proceed.
Thank you, Chair. So this, can I just hear if I'm clearly visible, audible, Chair?
You are audible, but not that clear.
Thank you, Chair. Let me just improve the sound now.
Now you are clear. You can proceed.
Thank you, Chair. So we will look at the status of HPRS in the province. We'll also look at the utilization, monitoring its progress. We will be looking at computerization and broadband connectivity, the audit action plan segments, the post-audit action plan for 23-24, the audit findings by the AGSA for the same year. We'll also look at our action plan and progress, the challenges and our remedial actions, and then our recommendation and conclusion, Chair. So as indicated by the previous presenters, it has been developed and set up to provide a patient registry and master patient index service using the South African ID number and all other legal personal identification numbers, e.g. passport numbers, as the primary identifier, making it possible to track patients across all levels of care and thereby improving quality and continuity of care. In the Northwest Province, the system has been implemented since 2017 at primary healthcare level and at hospitals as from 2024. Initially, it was rolled out to all facilities as part of the national health coverage, including receiving computers and connectivity routers to enable the system to be operational from the national office. And the table below depicts the number of patients as registered and as referred to by the Honorable MEC. As at the beginning of June, we've registered more than 3,401 patients on the system, and of those 10,552 that follow-up visits to our facilities. So that is out of a total population of 4.155 million that we've registered. So we're still short of registering the full population on the system, Chair. But that is things that we are working on, as indicated by the Honorable MEC. 101 of our facilities of the 390 facilities are actively using the HPRS system. And that is based on the sync data that we've received for the months of June and May. That shows that there is movement in terms of the facilities that are using the system. Chair, just to indicate that our critical dependency for this system is to make sure that you have functional,
foundational information and communication technology hardware. And as indicated, many of our clinics within the province is not connected to the network and uses mobile routers for the purpose of sending data or even uploading data to any of our electronic systems. But we are working closely with the Office of the Premier, which is our service provider through CETA, for connecting our facilities. And for this year, we've registered for 104 facilities to be connected to the NWPG network. There was mainly in respect of HPRS, two AGSA findings. The first one was the ineffective utilization of the outpatient registration system, where the AG found that the North-West Department of Health had implemented the HPRS in healthcare facilities, but however, utilization was still not effective. And there was also issues of lack of training, lack of established ICT support in clinics, and lack of minimal connectivity and use of manual processes that contributed to the ineffectiveness of the system. And then they made some recommendations where we must work with the National Department of Health to regularly monitor processes, to ensure that the system is used consistently and effectively, that we do a review of our patient records to ensure that patient records are complete and up to date, that we provide training, and that utilization should be addressed at the Provincial Health Information Systems Committee. The root causes that was identified was that we have an outdated operating systems and aging computers at facilities. And as with Limpopo, it is also the case with Northwest that some of our versions are still on 1.13 instead of 1.18 as it should be. The issue of ineffective training of users, and there was lack of adequate monitoring of utilization of the system. And the second finding was that HPRS is not implemented in all the health facilities. So the AGSA found that there was about 40 facilities where it was not implemented. And so I'll give a response on this for how we've progressed on this. The recommendation was, again, from AGSA was utilization of implementation should be addressed at the Provincial Health Information Systems Committee, and that we should again work with National Department of Health on monitoring the usage of the system. So here we then divided the audit action plan into the following two parallel segments with clear objectives. The first segment was to improve the adequacy of controls in the manual systems currently in place. And the objective is to improve the audit outcome by AGSA in a short period of time, and then moving from manual to electronic systems, and to completely move away from manual tick registers and patient files. Here, this is just a snapshot of the post-audit action plan. It's not a complete post-audit action plan, but these are the ones that were relevant to this area. It was in terms of incomplete and inaccurate information reported in the annual performance report. And that was in terms of ineffective reconciliations, that is on your AOPO audit, and the utilization of manual records. The action plan was to reconcile data between DSIS and registers through reconciliation tools on a monthly and quarterly basis, and compliance to be monitored. And we can confirm that these things, monthly and quarterly reconciliations, are done, Chair. We are comparing information from patient file tick registers and what is recorded in the GHIS throughout the month and the quarter. And the reconciliation is done in all facilities by the reconciliation team. And the final output is reviewed by and approved by the OPM and or CEO, and that's been achieved, Chair. We share business processes on all the indicators with all data capturers, information officers, and head of institution. And the objective or goal is to retrain all data capturers, information officers, and head of institutions to ensure that everyone has the same understanding and follows the same processes of proper classification of information per data elements. And that action has also been achieved, Chair. In terms of accuracy tests and audits performed on biannually to provide reasonable assurance. And we can confirm, Chair, that audits are carried out by audit teams at the sub-district level, which includes sub-district managers, facility managers, OPMs, information officers. And the purpose is to audit to give reasonable assurance that reconciliations are being done correctly and accurately. And the audit reports are used to identify risk facilities that need special attention. And we can also confirm that that has been achieved, Chair. Providing supporting documentation or to be scanned and loaded in the SharePoint for all indicators with an output of 5 or less in a month. We introduced a system called eHealth to focus on data elements of low outputs, and these are high risk during audits. And we were able to load supporting documents to this system, and quality checks were done to ensure accuracy, and that has also been achieved. We also needed to implement the ICT turnaround strategy, and the department to perform full assessment of all facilities that are not using the HPRS system effectively, and further monitor utilization rate per facility as per the reports we received from HPRS. So then on the specific action plans on the AGSI findings and on the ineffective utilization of the health patient registration system, as indicated, the monthly reports are downloaded, and those reports are shared with the facilities and the districts so that they can see which facilities are underutilizing the system. But as indicated, utilization in some facilities still remains low, as indicated in our previous slide 5. We do have master trainings on the use of HPRS, and we have scheduled 2 training sessions for August 2025 and January 2026. And the same report that we request on a monthly basis will also be reported at our Provincial Health Information Systems Committee as a standing item on the agenda. This committee meets quarterly, and our next meeting is scheduled for next week, June. And this is also where we will then have discussions in terms of this committee to make the recommendations to the Departmental Management Committee. In terms of HPRS, it's not implemented in all our facilities. So we can report that 255 out of 270 clinics and 46 out of 48 community health centers and 16 out of 19 hospitals, that is district hospitals, regional hospitals, tertiary hospitals, are utilizing, or the system has been implemented, although not fully utilized. We still have about 20 facilities remaining for installation. That is an improvement from the 40 that the AGSA initially identified. There we do have challenges, but we also have remedial actions. Our budget is severely reduced every year. You can see the reductions over the 24-25, 25-26, and 26-27 years, starting at 421 million, 443 million, and 460 million. But we will continue to engage either the provincial, national, as well as the National Department of Health on our budget shortfalls experienced. And we've also reported this to the EXCO of the Provincial EXCO to assist us with budget, because for us to achieve some of these activities, we need the relevant budget. We're sitting with outdated hardware or computers. Those need to be replaced, especially those with the unsupported computers. But we will also engage private sector to donate or assist with replacement of hardware. We do have issues, as indicated by the Honourable MEC, with network connectivity or connectivity in general. And that is mainly due to the rural nature of the province. But we are also currently busy with a project through ICASA's PSI obligation, wherein Vodacom is installing routers at our facilities through a National Department of Health project. That is the SA Connect project. So hopefully more of our facilities will then have connectivity for us to use HPRS more effectively. We're also sitting with the issue of cabling of facilities. Most of our facilities, due to them being very old, has not been cabled, but where we build new facilities or replacements, that is part of the bill of quantity, where those are things that are now part of the strategy to update those facilities. But we also sit with a lack of insufficient ICT staff, We have managed to advertise various posts at our provincial head office, but we still have facilities and districts that still do not have sufficient ICT staff and skilled IT technicians to manage the process of HPRS or any electronic system we have at facility level. And there's various factors that led to us not having those sufficient budget for those staff members. Chair and Honourable MEC, this report is tabled for noting. Back to you, Honourable MEC. Chairperson, I'm done. I'm not sure if Honourable MEC Larry is able to. I'll hand it back to him.
Thank you, Acting HOD. Honorable MEC, are you fine? Can we proceed?
Yes, we can proceed, Chair. Thank you. And thanks, Chair, for understanding, because I had an agent meeting with Premier to discuss the issues with Cancer Alliance that I think you all know about it. Thanks.
Thank you, Honorable MEC. So over to you, MEC of Gauteng. You may proceed with your preliminary remarks and then you can give over to the HOD.
I will not even waste your time, Chair. I will just hand over to the HOD to present. Then I will take the questions after that. Thanks.
Thank you, Honorable MEC. Honorable HOD, over to you.
If I have the CIO that is with us that is supposed to go through the presentation, Madam. If we can give it to CIO with your permission, then HOD will assist in terms of the questions and myself. Thanks. CIO, apply.
Okay, thanks, MEC.
Okay. Okay, thanks very much, Chair. Good morning again, MECs, HODs, and the members on the call. Again, Chair, my name is Anele Apleni. I will be taking you through the presentation on the HPRS, which is the Health Patient Registration System. If you go to the next slide, Chair. So, particularly for Gauteng, the first implementation of the HPRS was in 2017. So basically, Chair, this project was mainly driven by the National Department of Health. So during that period, an amount of about 333 facilities, which includes obviously the stations and the hospitals, have implemented the HPRS. So during that process, what then happened is that the National Department of Health did provided the tools of trade, which is the PCs, and some means of connectivity, which in any way they were a bit limited, which I will explain in the next slide. So basically, in this sense, the NDOH was the key convener in terms of driving the implementation of the HPRS itself. So what that means is that the whole system implementation, including the creation of the user accounts, the technical support, was actually managed and centralized at National Department of Health. So that on its own, Chair, has posed certain problems or challenges around the provinces in terms of supporting the implementation of the system. However, that we have noticed that there was some serious inadequate in terms of the usage of the system. That was mainly because during over the period, there were some challenges around the network performance. So the way the system works is that it is an online system. So basically it requires a full bandwidth connectivity so that you can be able to access the system on the internet platform. So basically what happened is that at some point there were some of the facilities that were excluded. Just to mention, Chair, as well, that the HPRS does make a provision for the biometric, which actually interconnects to the DHA in terms of the fingerprints. If you go to the next slide. So, Chair, the next slide just depicts the level of maturity in terms of the provincial systems. Just to give an indication, the province has implemented a full-scale health information system, which is quite agile and very robust. And what do I mean by that is that the system itself does cater for what we call it interoperability standards. It includes one of what we call it the integration, so that any system can actually be able to interact with our system. So far with the HIS, we've managed to implement 3 modules, which is the patient administration, the billing, and the revenue in all the 33 CACs and 37 hospitals. Obviously, we have gone through the process of what we call it user testing and acceptance. So far now, we are just busy concluding what we call it the clinical module, which now will actually derive the whole concept of a paperless environment. So thus far, we've implemented workflow in one of the hospitals, which is a Mamelodi, which has been accepted. Then on the 29th of November, we have managed to promulgate the clinical module at the Mamelodi hospitals. So far, we've successfully integrated what we call it the SEP to the PACS, which is the radiology system. And we are just planning to roll out in another hospitals, health facilities. If you go to the next slide. So on the HIS, in terms of its capability, if you're looking at that graph, my apologies that the graph is not really clear. At the left bottom part, it has got a capability that shows the component of the integration to the HPRS. This is one of the key fundamentals and the key ability of the HIS itself in terms of the readiness to implement the HPRS. So we are at a point, Chair, where now we are just finalizing the issue around the integration so that the HPRS can be able to actually write back to the HIS so that we don't have an issue around the duplication or else the dual system in terms of the patient health records. So if you go to the next slide, where are we in terms of the strengthening of the key considerations in terms of assisting with the system itself? So one is around the issue of the absolute infrastructure. I think the other colleagues have already covered. So this is where in terms of ensuring that our backbone has got full connectivity. And number 2, obviously, we're looking at the integration of the HPRS with the HIS system. That matter is already ongoing, and we are busy engaging the National Department of Health to assist us in that, as well as we are just refreshing what we call it the end user devices in terms of the what to call it tools of trade, as well as one of the issues, Chair, that will be driving, it's around the resource and change management so that we can ensure that our end users do understand how to utilize the system. So how we're going to implement that? Obviously, we're going to implement it via a phased approach rollout methodology, where we'll actually have a trainer, a train of the trainer, so that the users can actually be able to independently use the system, and we can have resources within our system that will be able to train other users. Obviously, one of the key critical areas is to define the user rules in terms of the HPRS and the ICT stuff. This is quite critical, Chair, so that we can be able to support the system on its own independently as a province and not relying much to the to the National Department of Health. If you go to the next slide. Okay, Chair, I've already covered around the issue of the network infrastructure. So mainly what we are looking at the core set is that we want to upgrade our LAN environment, and we want to put what we call it a wireless network so that it supports the HPRS traffic. As I already indicated, that this system, it does run obviously on the online services platform. So that will actually ensure obviously the reliability of the internet, and we also want to have a failover in terms of the backup. Then on the issues of tools of trade, obviously we have already done a technical assessment so that we can identify the level or else the specification of the equipment that will be required to support the HPRS. If you go to the next slide. Then on the next slide, Chair, we're just making reference, obviously, of the training so that we can have simulation labs so that users can start to understand how to utilize the system. Obviously, we'll also be implementing a centralized help desk, which we already have in the department, but we just want to incorporate the part of the HPRS so that our help desk support can be trained on how to immediately assist the users. On the human capital, in terms of the resources, I want to collaborate, obviously, with the national department so that we can have skills transfer around the support and the usability of the system itself. Then if you go to the next slide, Chair, then we'll talk about just the change management, which I already covered, including the data management in terms of the support. In conclusion, Chair, what we are putting in place in terms of the way forward, obviously, we just want to indicate that we're going to be collaborating with the National Department of Health in terms of ensuring that the system is fully deployed, and obviously we'll be implementing there's a meeting that has already been scheduled in terms of the integration with the CSIR so that they can assist us in the implementation of the integration. The way the integration is going to be working, Chair, is that it's going to be using what you call it a push bulk data, meaning it's going to be from the HRS to the HPRS. And as well, that just to indicate that there is no bi-directional pushing of data. In other words, the HPRS will only be writing back to the to the HIS so that we can ensure that that integration has been completed. As I already indicated that the end user requirements has been concluded already, and what we have done in the province is that to make sure that there's a sustainability around that is that we have nominated a team that will be working specifically on this issue so that we can quickly expedite the issue of the implementation. So as part of the conclusion, Chair, around the actual action items, so what we are doing is that to strengthen our network is that we'll be leveraging on the RT15 contract in terms of the procuring of the APN solution that will be deployed in our 300 clinics. So basically, the APN solution will provide an access to the internet services via a secure channel. So what do you mean by that is that we want to make sure that that data is actually secured. We'll actually put a secure channel. And as well, we'll actually be implementing a similar technology, which is called the ADSL. This solution will allow clients to configure the environment on a private network. So this solution will be able to be customized quite quickly in the environment so that it enables each users to be able to have a profile and to access the system directly. In addition, the system will be able then to be controlled privately and be monitored so that we can ensure that there is no abuse of the internet services. In terms of the timelines, Chair, we are looking at finalizing the proposal where we are, as well as just getting the approval from the service provider under the RT15 contract, as well as starting to create what we call it, the account creation for the documents that will be submitted to the department. Once that has been concluded, then we'll be able to start what we call it the APN configuration. Our target date, Chair, is on the 7th of July. What that means then is that we'll be able to conclude on the issue of the documentation and start the implementation of the APN technology. Once that APN technology has been implemented, we don't have to physically install any devices in the health facilities. It will actually be working on the remote access so that it will be quick for us to support and install the network in those health facilities. So, Chair, this is where we are in terms of the implementation of the HPRS as far as the network connectivity is concerned, which was actually one of the issues that has been raised as part of the audit finding. That will actually assist and share this project and to have an appetite and pick up in terms of the usability of the system itself. Chair, at this point, I will hand it over to the CFO just to take us through the next slide in terms of the audit findings. Thanks very much, and thanks very much, MEC.
Good morning, Chair, Honorable Chair, and MECs, HODs. Apology, I was just trying to unmute myself. We're providing progress, Chair, here. My name is Montodi Botsani, the acting CFO for Gauteng Health. We're providing progress in terms of the AGSA findings. This is the status as at the middle of June. We're just indicating here, Chair, that we have had about 138 matters that were part of the AGSA findings. To date, we have implemented 93, and then 45 are also still in progress. We are also indicating some of the stages around some of the matters that were identified in the AG findings report. But to date, we have implemented 133, and then about 89 are part of what is still in progress. So these matters are those that were not affecting the audit report as included in the management reports. I can move to the next slide. The next slide is just a depiction in terms of the percentage of the matters closed, mainly relating to those that are part of the Gauteng Audit Services findings. So some of these findings, before they can be progressed to the department, the Gauteng Audit Service do their own findings in terms of the progress that will have been made by the department on the matters they have raised, including those that were raised by the Auditor-General. So we're just providing progress from the period of 2019-20 to 2024-25 in terms of the progress that we have made. So we are seeing here that the matters really went down in terms of those that were attended to for the Q4 of the financial year 2024-25. In the next slide, Chair, there were a number of the matters that are of a repeat report findings. There were matters of a repeat findings, and then these were about 13 matters that were identified. This relates to the limitation of scope. We are just indicating at this stage how we have managed some of the matters raised, mainly relating to the health information system that we have implemented mainly to address some of the shortcomings that were identified. Relating to the performance in terms of the inaccurate and incomplete data here, we are indicating progress that has been made, including some of the controls that were implemented at different facilities. We have also looked into the data verification team effectiveness, mainly throughout the entire department, where the resources have been made available to the facilities to ensure that the matters are being addressed. Can go to the next slide. The next slide relates to the patient experience of care surveys that were performed. And then in this regard, there were issues around the consent forms that were a matter of a matter that needed an attention. At this stage, we have had an engagement with the National Department of Health, mainly to look into the calculation format that was used to measure the patient experience of care. There were also matters raised in terms of the Program 8. This relates to the infrastructure program around the disclosure in terms of the work in progress register. At this stage, what we have done, we have already attended to the matter by ensuring that the exercise that needed to be done to conclude the work in progress register has been finalized. Go to the next slide. There was also a repeated finding around the contingent liability. I must maybe safely to say that the department has managed to reduce the value of the contingent liability that was disclosed in the previous financial years, around 20-odd billion. We are sitting comfortably at around 7 billion in terms of the contingent liability. The main issue here was more to do with the audit assessment, including some of the duplicates that were found. We have at this stage removed and cleaned up the contingent liability register. We have also, as part of the strengthening some of the controls, have the approved standard operating procedure in terms of how this contingent liability could be dealt with. In terms of the assets verification, is one of the finding that has been a repeated finding. At this stage, there has been a rigorous asset verification throughout the department for the period 24-25 financial year. We have also, as part of this, extended the controls that needs to be reinforced by all the CEOs in terms of the asset verification. We have just finalized the 24-25 asset verification process in terms of the key facilities, which are our academic hospitals, including the tertiary hospitals, because that the most findings were repeated in those areas. The next slide then talks through the human resource in terms of the staff that were appointed in addition to the approved staff establishment. I take that the main issue was here relating to the irregular expenditure under the assessment that was identified. There were also issues around the clinicians in terms of the contract sign-off process. But at this stage, we have already, as part of the cleanup, looked into the approval of the staff establishment. The process is underway just to finalize the reviewed organizational structure that was just implemented since last 2006. There were also issues identified in terms of the overtime payments. This issue also was dealt with in terms of the classification, including the controls. I take that at this stage, the matter is receiving priority in terms of a review from the National Department of Health. The next slide talks to the issues around the ex post facto payments. This related mainly to the issues around the SCM processes relating again to the fruitless and wasteful expenditure extended to the 30 days payment. I must just also indicate that the processes, including the measures that were implemented related to the standard operating procedures that were implemented, including the appointment of different committees within the BEC, BSC, including the vetting committees at different facilities. In terms of the 30 days payment, we have as well extended by including and presenting the new strategy in terms of ensuring that we pay our suppliers within 30 days. Some of the challenges related to the accruals that were incurred during the former COVID-19 incident. So at this stage, some of those accruals that were incurred at that period are being come off so that they can be verified and validated before they can be processed for payment. There was also an issue raised as a repeat finding in terms of the participation. If you can go to the next slide, participation in terms of the contract with another state organs. This related mainly to the SCM policy, where the department had to participate in terms of the contracts relating to food. At this stage, we have had an opportunity to award our own contracts. And then we have also, as part of this, from the July 2024, we have prepared, and then the participation was limited as we have awarded our own contract. There were issues raised around the disciplinary steps in terms of the irregular expenditure that was incurred from the former financial years dating back 5 or 6 years ago. At this stage, as part of this, there was a breakdown that was provided, and then we are, as part of the recommendations from the Department of Justice and Labor, have requested for secondments in terms of service delivery agreement to expedite some of the cases that were identified as part of the irregular expenditure. Issues around the consequence management from the HR. We have, as part of the strengthening and measures to mitigate against this, have applied for the condemnation applications, but could not be finalized due to proof of consequence management as part of what we have referred to the Justice Department and Labor to assist in that regard. Maybe, Chair, let me pause there because these were the issues that were part of the repeated findings from the AG and the mitigating measures that we have put in place. Thank you, Chair.
Thank you, CFO. Thank you, MEC, and the team from the Department of Gauteng. Honorable members, we are now with the with you for questions of clarity or any concerns regarding the presentations. I can see Honorable Sibande first, Honorable Adriaanse second, and Honorable Aris third. Fourth is Honorable Du Plessis in that order. Honorable Sibande, over to you.
Thank you, Chairperson. And without wasting any time, I wanted to commend all the provinces who were invited maybe to come. But at the same time, allow me, Chairperson, through you to comment something, you know. Chairperson, I think you took nearly about 20 minutes. We started after 20 minutes about our meeting. Around requesting provinces to start or also to name their gadgets. I don't think that is correct. 20 minutes is too much. And then again, people, including ourselves, in terms of a PFMA, we mustn't forget that we are accounting officers. I wanted you to put that record straight. And also, to the provinces, all of them, I wanted you to suggest that, you see, Chairperson, there are two types of visits. It's unannounced and announced. I think in some of these provinces, we need to visit them unannounced. I'll explain one day. But to go specific to the questions. Chairperson, let me start from the first one, which is the Limpopo. You see, but some of the things it cross to all of them. That the issue of the old gadgets which they're using, old computers and the like. But I wanted maybe to come up with something with these ones. No? You see, Chairperson, I'm very much concerned about the number which they've given us in terms of the stats of the number which they've captured. That is 7.2 million versus 7.8 million. And I know that they gave this the reason that it might be a duplication and it might be the issue of foreign nationals. But from my side, allow me to say sometimes it can be a negligent of some of the management. Because what is happening, some of the people are given a job to do, and then they'll sit at the end, towards month end, they will start to try to give more stats as if they are working very hard, while not. That thing must be corrected. And then also, with the Limpopo, I wanted to raise something, Chairperson, which is maybe I need them to assist us. They've indicated about the issue of old things, and then also there in terms of compliance, they've raised an issue that some of these things assets were sold, or I mean, they were accused that they sold the asset. Why they themselves, they thought that this thing is just better to be donated to it, something like education and like. But they also solicited by saying it was much better to donate with those things. If the things is not user friendly, I don't know how to deal about that thing. To me, it is a contradiction that themselves they said these things are old, but now when they're supposed to take them out, they feel that they can still use them. So that is a contradiction. And then also, I was concerned about that issue of the human resources, the findings about the issue that the people who have been paid overtime and the like, and the issue of the incorrect dates. To me, I wanted you to find out how much, or the issue of financial implication, how much was lost on that one? And then let me go to the last one to them, is the issue of duplicate of payment and the lack of technology. I can't understand with that one. The issue of duplicate of payments is like some of the people, normally they throw out the javelin and then resign. They know that they'll get the money outside because we don't have a system to follow the people. And then go to the Northwest. To Northwest, the findings from the HE, like the lack of training and monitoring. See, there is something which is killing me in that regard. If there are clear findings and then they said at the end, they've attended that 100%, 100%, 100%, that's where comes this thing of visit, of unannounced visit, to verify that is it true that 100%, or there is still, it's a process maybe to break that situation. And they've complained about the utilization of manual records. If they can clarify that's on that regard, because to me, if they've got an experience of a problem, a challenge of a network and alike, yes, manual is okay. They can, because you must have plan A and plan B. We know very well that plan A is auto, but what is their plan B in that regard? Because they've indicated that manual is if it's a challenge, since they've got a network connectivity. And then to Gauteng, all right, before I reach to Gauteng with the Northwest, they also complained about the issue of which one is that one? There is sorry, ma'am. Let me go to Gauteng, yes. Gauteng, they gave us the National Department, they said National Department provided tools of work. Okay, fine. But they've indicated that has contributed to challenges. But at the same time, towards the end, I've got a problem whereby they are very strategic, very close to the national office and whatever. But the AGSA findings, 138, it's worrisome, it's too much. The number is worrisome about the findings. You see, my question to them, where is the risk management? Where is the consequence? Where was the consequence management in that regard up until they reached so much number of in terms of the findings? And also, what is worrying me, Chairperson, before I close my questions, Chairperson, we mustn't hide this thing. Some to this one, to all the MECs, I want to kneel down and beg them that they must take us serious. Because if you recall very well, in our visit to different provinces, some MECs, they were nowhere to be found. Some, they came and greet us and then disappeared. They didn't accompany us to some of the places where we're supposed to go. That is a very, very mistake. And then lastly, with this one is the issue of fruitless and wasteful expenditure and also irregular expenditure. The issue is that it is very much important to us to know the issue of financial implication, how much was lost and how much was recovered. Unlike to give us just a statement that there was this, and then you don't give us exactly. If you are achieving a goal to cement or to correct that thing, but give us exactly how much was recovered. Thank you, Chairperson.
Thank you, Honorable Adrian. Thank you, Honorable Sibande. Over to you, Honorable Adrianse.
Uh, Thank you, Chairperson. Just switch on my video for a short period so that you can see it's really me. And then I'll switch it off again for everyone's bandwidth. First of all, I would like to thank the presenters for their presentations and the effort that went into that. However, I'm a bit bamboozled by what is stated in it, and it differs from what we received and what our own research shows us. So in 2019, 2020, 2022, and 2023, despite the fact that computers are old and systems are old, there was zero budget spent to improve this. So how was this considered strategically acceptable to approve these budgets with no allocation, while the risks identified by these computers that makes them unable to capture implement the HPRS system is listed by the department itself. Then I would like to know, in addition to this, that in the readiness audit, that you had to have a minimum infrastructure, requires stable power, secure server room, broadband, and trained data capturers. This is now aiming at Northwest. Now, I would like to know and have a list of the facilities that still fall short, together with the specific gaps per facility that's still there. I mean, it's fine to say this amount is they covered and they're fully operational, but there are still gaps at some of these facilities, and then there's some of them that's still not operating at all with the HPRS system. Whenever there's a fire at a facility, I'm stressed because I know patient records might be lost. And the second question added to that is indicate the estimated cost and timeline to bring all the facilities in every province, not only Northwest, to compliance. Because how long can it take? Most of the provinces started at 2070. And it's 8 years later, and still nothing is happening, and it's not done yet. So it's a very slow process, and during oversight, we see the lack of a sense of urgency as well when we see the data capturers lounging around. If we look at the Western Cape and KwaZulu-Natal, who ring-fence between 1.5 to 2% of the equitable share budget for e-health, why was a similar preemptive investment strategy not adopted by the Northwest and other provinces? It was right from the start by the technical committees it shows repeated recommendations to prioritize connectivity because this system needs connectivity. Why were these recommendations not implemented? Then I would like to know, provide the percentage when we look at the statistics of those that registered on HPRS according to the population per province. I would like to know the percentage this represents of the estimated uninsured population of each province. And then I think I've covered all the questions. Yes, let me just, I'm almost done. Yes, I'm done. Thank you, Honorable Chair.
Thank you, Honorable Adrianza. Honorable Aris.
Yes, good morning, Chairperson, and thank you very much.
Chairperson, I want to fully concur with what Honorable Sabandi was saying in terms of the HR. Because when you look at Limpopo as well as Gauteng, the biggest challenge in this facilities are the lack or the failure of the human resource department. Because and we must seriously look into that, because we can sit with a situation where it is supposed to be the people that must be held accountable. We need to hold them accountable, because many of times it is the senior or the junior officials where consequence management is installed, but we need to hold the facilities heads accountable for the failures of the HR, because it say to me that there's a lack place. And then also, Chairperson, I
Honorable Aris, we can't hear you.
and I think Honorable Adriaanse did touch on that. They have presented in terms of the population side, it shows 1.8 million. So I just need clarity on that. And then also, Honorable Sabandi did touch on that one of, people on maternity leave. This must
Honorable
give us, this department must give us a report so that we, install. Hear me, Chair? Can you hear me, Chair? Chairperson?
Honorable Aris, we can't get your questions. Is it possible maybe that you can write it in the chat?
Okay, sure, Chairperson.
Yeah,
Chairperson?
Yes, Honorable Aris.
Chairperson, can you hear me?
I can hear you, but you are...
Chairperson, Northwest Health officials that is currently in court for corruption. We need to get a report on that, and we want to find out what monitoring measures are there in place to prevent that this type of corruption is happening again. And then also in Northwest, in terms of their staff shortages, there's shortages of medicines in these facilities. So we want to know what is it that the Northwest will do to improve the services, to our people. And then, Chairperson, in Gauteng must give us an indication of there was more than 4.8 billion of invoices that was outstanding, that service providers must be paid. We want to know what's the progress on that. Thank you, Chairperson.
Thank you, Honorable Aris. Honorable Duplessis.
Thank you very much, Chair. I'm just going to quickly try to get the video up and running, but just so that you can see that it is in fact me, and then I will. So I'm going to start with the HPRS system within the various provinces. My first concern is the fact that Gauteng didn't want to participate or did not send any information through to the select committee researchers in spite of being asked. I'm not sure if this has changed, but if Gauteng could maybe let us know why they felt it unnecessary to partake within this study specifically for HPRS, and also more specifically because it has been a budget point or expenditure point since about 2016-17. Then for all the provinces, Gauteng, Limpopo, as well as the Northwest, what has your expenditure been towards hardware and software in 2019 and 2020 to 2023, 2020 to 23? The reason why this is an important question is a lot of money has been spent on a system, HPRS system, that has not been implemented necessarily correctly. And it shows when we do oversight at various places. It is a big concern that that this is not that it is not fully implemented yet, or that it is not massively successful throughout provinces. It also seems that the digitization of hard copy patient records are a problem within each of the 3 provinces that reported today. By and large, my colleagues that went before me have covered the HR issues and as well as the old ITC systems. Then, with regards to the AGS and the Auditor-General, the Auditor-General findings, for Gauteng specifically, it is very concerning that the AGSA could not determine the reported achievements either in district health services or provincial health services, and more so because I've done oversight in both of these, in many of these entities for district as well as provincial health, and these clinics are not working very well, and the hospitals neither. So I'm concerned that things have been reported that were not achieved, or something is missing there. It basically just says that the reported achievements did not have adequate evidence to provide the auditors with enough information. And considering that health sciences is actually a science, it really does depend on data, and it is concerning that there is no data to support or to at least show what is happening and whether or not these achievements are correct. There are a variety of other material misstatements and findings. However, I'm not going to go through them too directly. It is just concerning that there is no consequence management, and it feels that we're getting lip service about misspending our finances within the health department. And this being one of the core ways in which we give dignity to the people, I'm very concerned that we're not taking it seriously, that when people have stolen or misappropriated money within the health department, that there is serious consequences taking place. So if Gauteng could just give us more clarity with regards to that. Thank you very much, Chair.
Thank you very much, Honorable Du Plessis, Honorable Makwele.
No, thanks very much, Chair, and greetings to honorable members, MECs from Gauteng, Northwest, and Limpopo, officials in the platform. Chair, I don't have many questions because remember it is very unfair to interrogate the report at this very late stage. But the only input that I'm going to make amongst all the province, because the only province chairperson that we have officially, not the one that Honorable Sibanda indicated, which we are going to do as the select committee, because we realize that when we do what we call an open oversight, the oversight that the province know that we are coming, they normally choose where we have to go. And then they don't normally choose the place where there are problems. Because even because remember, colleagues from provinces, MECs, when we are saying that we are requesting a presentation, on the issue of the audit and even how to deal with the issue of paperless, we are not here to police you. We also want to assist you, because I can see all of you when you present, you only painted good picture as if that everything is fine. That is why, Chair, I will then agree with Honorable Sibanda when he was saying that, which I know that myself and yourself as a whip, we are busy making sure that we'll have those unannounced visits so that we are able to assist the colleagues in the provinces, because that is the role of oversight. Because as we are doing oversight, we want to assist the colleagues to make sure that they do things properly. I know that we went to Gauteng, Chair, whereby I don't wanted to paint the MEC in black. The MEC was with us in Gauteng. The only place where we never get MECs, it was in Western Cape, which the message that the Honorable Sibanda want to put it across, because when we are in the select committee where we want provinces to account, we want the MEC, because the MEC, they are the one with authority. We don't want we don't want only the HOD or the departmental staff present to us only to find that they can also make commitment that they can't fulfill. That is why it is important for the MECs to make sure that when they come, they lead the delegation so that they are able to take everything that they present. But Chair, with regard to their presentation across, especially on the issue of dealing with the thing of paperless, because these things of files in our health facilities, the one of paperless, it is the one that make our health system across not to be effective. Because you'll find that today this patient come to the hospital, you are looking for the file, that file is missing. I know, Chair, when we were in Western Cape, we then realized that they've made, because that thing is to make sure that everywhere, when the patient go to the clinic or go everywhere, in terms of his health history, we are able to trace how far is it, what is the problem, because otherwise the patient can go there only to find that as the health facility, we are able to trace his or her health problem. But generally, I will say this, Chair, because I'm from Limpopo, which is a rural province. I know also in Gauteng, even though it's an urban province, we once went to the Lope clinic, which that facility, it was not, the standard was not the same as the ones in town. But what we need to do, colleagues, because the health service matter, especially at the deep rural areas, where we must make sure that the same system that we want to come to implement in the department, it is also implemented at the deep rural area. But safe to say, with the report that we have received now, Chair, without wasting your time, across all the provinces, I can see that there is a stride. They are doing well in making sure that at least we're gone are those days whereby you go to the health facility, they said, no, that file, we don't see it any longer, and stuff like that. But over and above, with regard to the issue of the audit action plan, we can see that at least the Department of Health across the province, there is also an improvement, even though all of them, as they've been presenting, the issue of consequence management is still an issue, because where they raise that their problem, they are unable to tell us that, what action are they doing to make sure that, because in the department, the money, we can't lose the money, then everything, then it's end there. No consequence management, no action. Because if there were people that they involved, those people, they must be arrested. And then those people, we need to trace so that the public's money need to come back to the public, to back to the government. So actually, that is the only thing that they'd like. But over and above, Chair, we welcome the presentation from all provinces. I thank you.
Thank you, Honorable Makwele. Honorable Feni, over to you.
Thank you, Chairperson. Let me just show once my face, and then is I will just switch it off. Let me take this opportunity, Chair, to greet honorable members, honorable MCs, the different departments from different provinces that are within our midst, our support staff. Chair, I must also appreciate and applaud the progress that have been made and the strides that are being put in place in ensuring that there is a betterment in the health service system of our people, because majority of these people that are being affected, when all of these things are not delivered as expected, are the most vulnerable of our communities and are the ones that we are claiming to be presenting. So our role as members from different provinces is indeed informed by such in ensuring that we are the mouthpiece of our provinces, as we have already been done in other provinces. I think we are focused indeed on that. We are constitutional mandated to do so. We are not doing that on the basis that we are friends or we came here to safeguard a certain interest, but we are mandated by the Constitution of the Republic. So our oversight role is informed by that. Chair, I think it is generic that our public service are having challenges. If we talk about health, if we talk about education, so on and so on, you discover the question of infrastructure is cutting across the board, specifically on health, as we have already alluded. If we can even go out now just to see these institutions that we're talking about that are servicing the majority of our people, we discover that these challenges are there. In some, there are improvements, in some, it's worsening. So my chair is my question will be across these provinces. Hopefully, will be captured when is being responded and to. Is how far in terms of your NDP 2030? Because I believe that it's a policy, government policy that is guiding nationally on how we must respond to these particular challenges, whether we talk education, health, so on and so on. Specifically on health, in this instance, I think we are left with 4 or 5 years in terms of when we're making our measurements, our performance, our practical performance. How far have we gone on different provinces now that are here? I won't say Limpopo will do also the Northwest and then the Gauteng. If we can say that we are using what NDP 2030 have put in place in order for us, whatever our planning that we're doing, whatever our budgeting that we're putting in place, that we can safely argue that in order for us to achieve that particular plan, because that plan is responding to the betterment of the life of our people. It's a government plan which seek to give us a particular direction. That's number one. It is a generic question to when responses are made, I will be pleased. The second one, I am a believer of NHI, even though we might differ and try to disagree, but NHI is a means to achieve this betterment of our public health system. It's an improvement, whether you talk infrastructure, resources, whether you talk IT, it cut across. If we can just highlight, I know it is not the meeting for that, but I must raise that question because some of the issues that are being raised here, if your IT system currently is not responsive to the current challenges, people are still having an access of files. You take your paper files, you go out of the of hospital, and then when you feel you come back again, then it tells you that we are not yet there. So I just want to check that with the challenges of the IT that have been raised, can we safely argue that if tomorrow we can agree that let us start with in fact, as we agreed that is a government program, let alone the question of challenges that are being made. Can we safely argue that we can successfully implement it without any hassles? Because one thing that is being utilized against government, by the detractors of the progress of government is the question of infrastructure. When we talk about the infrastructure, it cut across. So you are giving ammunition to them for us not to be able to move forward. So I just want also to check that. The last one is around the question of your consequent management. Consequent management seems not to be, across people, instead of being, facing the music. Sometimes you discover that they are promoted if you were a manager, and then allegedly you are involved in something that is, unlegislative or unconstitutional, illegal allegations. You are given a higher position to a particular direction in the same department. How are we responding to these challenges? This is the case in one of the provinces where it was discovered that the tender that was given in a service provider with documents that were not necessarily legitimate, or documents that were not necessarily meeting the requirements. How does that, possible in a system that is being, monitored? Are we still going to say, no, we are going to monitor the situation, even though we find ourselves in a crisis? So I just wanted to check. I won't be specific in terms of this province must respond, but I think it's a generic question that cut across in order for us to see better services to our people. So those are the questions, Chair, that I wanted to raise, and also some of them are not necessarily questions that can be directly responded unto now, but just as a highlight specifically on the Department of knowingly what we're confronted. I know it's not an easy task, honorable MECs that are here, but in order for us to move this particular direction, I think as well going forward, we'll be able now to say, no, we raised this thing in our last meeting, but how can we are still having a similar problem? We appreciate the presentations. We appreciate also the reports that we are having. We interacted with the reports. Thank you very much.
Thank you, Honorable Fanny. Honorable Baines.
Good morning, Chairperson. Good morning, the MECs. Good morning, all the officials. I also want to open my camera so that you can see it's me. Chairperson, just for clarity, the presentations that I saw, Chairperson, are presentations of provinces, but not the Western Cape. I would love to know whether the Western Cape must still...
Honorable Baines, the Western Cape will be in the next meeting. So it's just these three provinces. So we
That
will.
is why I'm saying, Chairperson, for clarity, because all my questions that I have is actually directed to the Western Cape. So then at this stage, Chairperson, I'm done. Thank you.
Thank you, Honorable Baines. To the different departments, MEC, as well as the accounting officers. Mine is just in terms of Limpopo. They indicated that there were duplicate payments made to the service providers. I just want to know, did they recoup the money that was paid, and what is the amount of money? And is it recouped from the service provider or from the officials? Then in terms of the 7 facilities that the HPRS system is not implemented in, what is the program of action in terms of that 7 facilities? And then in terms of the number of healthcare users that the department already registered, it was not indicated clearly. And that one, Honorable Sibande have touched on it in terms of the population is fewer than the registered healthcare users. But do you, as a department, have a plan in terms of eradicating those duplications? And then in terms of Northwest, only 20 facilities still have to be equipped with the HPRS, but how about the process of transferring the information from hard copies to digital forms? How far are that process? And in terms of Gauteng, what are the number of healthcare users that are registered on the HPRS? And what is the duration of completing this digitization of the hard copies patient records to the digital form? That is all from my side. So we will request the Department of Limpopo, after them Northwest, and then Gauteng, in that order. Over to you, MEC of Limpopo and the team.
Thanks very much, Honorable Chairperson, and let's once again appreciate all the inputs that have been made by the honorable members, and let's also appreciate the fact that indeed the oversight is actually strengthening us and assisting us into doing better to our communities, and also we want to put it that indeed we are indeed committed to work together with the committee, because we know that you are here to strengthen our department. So we'll at all times avail ourselves to assist each other with the committee, so that we improve the services that we give to the people. And then in terms of the questions that were asked, I will work together with my team to respond to them. But what I want to say, Chairperson, is that indeed, as the Department of Limpopo, we ensure that in terms of consequence management, it's there, because we know that if there are no consequence management, then whatever it is that is being done wrong by our officials, it will continue happening if there's nothing that is being done with regards to that. I want to make an example with the question that the honorable members have asked of the duplicate payment that was made, to say for us the total amount that was spent on the duplicate payments was approximately 300,000. which was recovered, and it was recovered from the service provider, which was the National Health Laboratory Services, and the consequence management has applied in all the cases of a lack of oversight or supervision from the side of our staff members. And we are doing that to ensure that something like that does not repeat itself, and we ensure that everyone does their responsibility. And Honorable Chairperson, I would like to say to other comments that were made that we've noted them, and we will try by all means as the department to improve on them. But I would also like to give to the acting HOD together with the team to assist in answering some of the questions. I've captured the question of the auctioned computers and other questions were what informed the department into donating them. So I will, with your permission and Honorable Chair, hand over to the acting HOD, Dr. Ndwamato.
HOD, you can proceed.
Chairperson, can you hear me? Honorable
Yes,
Chair.
yes, HOD, we can hear you.
Thank you very much. Honorable Chairperson, honorable members, MECs, and everyone on the platform. We really appreciate this time that is given to us so that we are guided in terms of our operations. And also maybe just to start where our MEC has ended with regard to consequence management. So if, for example, a service provider has failed to repay back the funds, then we recover it from the officials who were responsible for that error. So this is what we do to say, as the MEC has said, it is a serious matter, the issue of consequence management to the department. I'll start from the end with the way I've noted the questions, and then other team members will come in where I have left some. With regard to the population duplicate on HPRS, our population that we've captured is more than the population of the province, and we have said that we think it's duplicate, including foreigners. And then an honorable member also mentioned that it could also be due to negligence on the part of the staff. So how we are going to resolve this is we would require that the system be decentralized, especially the support, the software support, so that we are able to identify if there are duplicates, because if the system has not synchronized, we are not able to see that there are duplicates. That's why for us at this moment it's a suspicion. So once we are able to pick up those duplicates, then we will be able to merge the duplicates file, and this can only happen when we have improved on our connectivity as well as the synchronization of the system, and we will work together with the National Department of Health, who are currently the support system to the provinces. And the 7 facilities that are currently not capturing, they have implemented initially. However, due to the problems with their computers, they are currently not capturing. The province is currently assisting with the gadgets at the moment, and this should be sorted within this month, because we have already identified the areas where we are going to get the gadgets in order to allow them to continue to capture. The issue of duplicates payment, the MEC has already responded on it. Maybe I can link this with an issue of overtime that was paid while people were on maternity leave. And this one, the amount was 1.7 million that we have identified during the 23-24 financial year. And all this amount has been recovered from the people who were paid overtime. So once we identified, we asked the person who to acknowledge that and to pay back. And in addition, we have applied consequence management to the people who has done the oversight with regard to the matter. And then with regards to, I think the comments on the last, before the chairperson came in, it was with regard to tracking our NDP 2030. As a department, we are tracking that. We are on track at the moment, and we have seen improvement, especially on the mortality. Some of the indicators that we are monitoring is issues of our maternal and child mortality, our HIV mortalities, and we are on track and we are monitoring that. And with regard to NHI, as a province, we are preparing our facilities to be ready for that, and we are evaluated by Office of Health Standard Compliance, and currently as a province, about 49 of our facilities have already been accredited that they are ready. So we are working hard to ensure that indeed that is done. And then in terms of the expenditure on computer hardwares over the years, as well as the number of hardwares, I think it would be, at the moment, we are trying to just put the information together. We should be able to provide that, but there has been, as a province, as part of trying to digitize to ensure that we are able to keep our data records, we have been purchasing computers over the years, and I'm just looking at the person whether they've recorded. They are still trying to collate, but I think this is the information that we will provide as time goes on. And we have also acknowledged the comments on the issues of human resource management, and that we also need, in addition to holding the people who create errors, we should also hold facility heads to that comment to ensure that every person in our department do what they are supposed to do, whether it's oversight within their facilities. And then I would like the CFO to come in with regard to the issue of, with your permission, with regard of asset management, just to give context in terms of why we auditors found us wanting in terms of the old computers that were no longer usable in our facilities. CFO will come in.
Thank you, Honorable Chairperson, Honorable Members, MECs, and HODs and colleagues. Perhaps I should just give, what gave rise to the issue of AG raising the findings against the action that we took by auctioning the obsolete or unserviceable computer related equipment. In terms of treasury regulation, the department is expected to first give priority to educational institutions such as any school, if ever they are prepared to can accept those identified obsolete items which are computer related, of which the department opted to go the route of auctioning, which is another option that is also provided in terms of the treasury regulation. Unfortunately, according to the interpretation, we were supposed to have gone first to Department of Education. If Department of Education is not in a position to can accept, is then that we are allowed to auction, meaning that we followed the process. Unfortunately, we failed to follow the first instruction. That was the reason why AG found us wanting. And it didn't mean that there was something, amiss or there was corruption. There was no corruption. Even the money that was, benefited as a result of the auction was, deposited into our revenue fund. That was the reason behind. But what we did, we went to an extent of also correcting that in the current, situation. We are now working, in collaboration with Department of Education when we dispose of all the items that are computer related. Thank you. Over to you, HOD again.
There was also a question with regard, if we had correctly the question, with regard to the estimated population of uninsured. So the population of Limpopo is 6.2. So about 8% are the insured ones, 92% is uninsured. So that that means the insured would come to about 500,000 also. So that was another question that has come through. The majority of the people in Limpopo are uninsured and they are dependent on the health system. And then in terms of the number of personnel who are capturing on HPRS, our own staff, I think we will provide the data on that one, but averagely on each facility, especially if it's a large health center, there are about 3 people who have been trained in order to capture data on the HPRS, but of the 471, we will send that information. And then I think the others were comments which we have noted and we are going to take into consideration, unless if I've missed something. Thank you, Honorable MEC.
Thank you very much, Honorable Chairperson.
Thank you, Honorable MEC. Over to the Department of Northwest.
Thank you very much, Honorable Chairperson and honorable members. As I said earlier, I'm here with Team Health from Northwest, led by the acting AG at the BM. They will respond to questions and thanks questions and comment from our members. After they have responded, if there is a need for me, I'll just summarize those questions. Over to you, Mr. Dibia, through you, Chairperson.
Thank you, Honorable MEC. Thank you, Honorable Chairperson and members. There was various questions raised for Northwest. In terms of the AGSA findings, in terms of Honorable Sibanda, where we said we achieved, so those are achievements on various issues that was raised by AGSA. We're not saying that we are 100% compliant, but we can improve or say that we have improved our audit findings for AOPO from with 2 levels, where we are now at qualified, where we were previously at disclaimer. So there has been quite an improvement in terms of our AOPO findings that we've done in the previous audit. Chair, there was also questions raised by Honorable Adrianse, the list of facilities that we will provide to the committee that is not currently available with us, as well as the cost to get all the facilities to be compliant. So those we will then submit to the committee separately, Chair. The CFO will respond on the issues of the budget as well as the expenditure on our equipment and hardware for ICT. There was also questions raised about corruption, Chair, and staff shortages and medicine shortages, which will then provide separate reports to the committee as those are available. I just wanted to check. On the issue of clinical record share, we are currently in the process of looking at the system used by the Eastern Cape, or that was developed by the Eastern Cape, HMS2. We've been doing visits to Free State, which has also started using the system. We have seen the HMS2 also through the health committee, technical committee, and we are currently also piloting a system in the province, post patient administration and billing system, which we also has a clinical module, which we are piloting at 3 facilities. So it's a process that we are following to make sure that we are able to move to a clinical patient record system. So that is all things that we are doing in the province. And just to indicate, Chair, that in the province, roughly about 13.5% of our population is currently on medical aid. So the remaining population is therefore using our facilities in the province. So it's close to but we will also provide the percentages of as indicated by the honourable member, in terms of the percentage of population that is using public facilities against the uninsured population. So we'll provide that information also as well to the committee, Chair. Let me then hand over to the CFO to report on the financial issues, and then I'll ask Dr. Tlhagane, our Chief Director for Corporate Services, to speak to the issue of consequence management, Chair.
Thank you, Honorable Chair, and good day, all the honorable members and honorable MECs and my colleagues. My name is Madire Rampedi. On the issue here, the question that was raised by the honorable in terms of the expenditure on the hardware from 2019 to 2023. In 2019, we spent 9.8 million. This was for the computers and the laptops and the routers. I will not give a breakdown on individual, but this is a high level in terms of total expenditure for 2019. And then in 2020, also we managed to spend 9.5 million on the hardware. And then 2021, it was 11.4 million. And then in 2022, we managed to spend 12.470 million. And then 2023, it was million. And then in terms of the current financial year, we are having a 31.9 million, which will also help us to address the facilities that are not being implemented, the 20 facilities that we have been highlighting. Though we know we are working under a very financial constraint, but we are focusing on the ICT in terms of the systems to improve efficiency. Thank you, Honorable Chairperson.
Thanks, Honorable Chair, Honorable Members, Honorable MEC and colleagues. My name is Madipuro Tlhagane. I'm the Chief Director responsible for corporate services in the Northwest Department of Health. There are questions which were raised by honorable members regarding to corruption and consequence management. I must indicate, honorable members, that the Department of Health in the Northwest, under the leadership of Honorable Lehare, takes this matter very serious. Previously, we did not have the director responsible for risk management, internal control, and labor. Those are the three directors which are working together to ensure that the internal systems are strengthened with regard to ensuring that there is no corruption in the Department of Health. There's also a committee which has been established to make a determination on the cases which are on the table regarding wasteful and fruitless expenditure and irregular expenditure. As and when it is determined that there are such cases where there is fraud or corruption, the matters are then referred to labor relations to make sure that those who are responsible are disciplined or charged, including the service provider, to ensure that we recover the money that we would find that there was a fraud involved in those matters. So those are the system that I've referred to that is in place in the Department of Health Northwest. Thank you very much, Honorable Chair.
Thank you very much, Honorable Chair and honorable members. I think Team Health from Northwest Department of Health, they have answered almost all the questions. In agreeing with them on medicine availability or shortage, we are doing well for now. As regard to the 80 threshold from national, we are around 82%, so we are doing very well. I think the rest, especially on consequence management and corruption, the Chief Director for Corporate Services covered me. Thank you very much, Chair. Back to you.
Thank you very much, Honorable MEC. Honorable MEC of Gauteng, you and your team can proceed.
No, thanks, Chair. Whilst the MECs come, if you through you, Chair, we will deal with a few questions that were raised by the committee members, and I think that the first one, I think was raised by Member Sibande, which is cross-cutting, and I think the rest of the colleagues will have dealt with the issue. Is the issue about infrastructure, aging infrastructure, and connectivity is the reality that we live with. And it's quite sometimes even surprising that in a province like Gauteng, you still have connectivity challenges. But the bandwidth that we require for the HPRS and including the scanning of documents and paperless system, it's something that currently we don't have it in its entirety. And I think the CIO in his presentation will have made reference to the plans that we have in place as far as rolling that out. But it is indeed correct that we are having infrastructure a challenge. But as far as and I think it was raised by a few members in terms of our maturity status as far as HPRS. And I think the first two slides of our presentation, Chair, also dealt with that to try and demonstrate that there's an acknowledgement that as far back as 2017, there was some attempts to roll out an HPRS as National Department of Health being the custodians. And then things would have been installed, layout, equipment, but there was lack of integration. And I think there's a member from Gauteng who said, I do oversight in these facilities and at the clinic level it's not functioning as optimally it is. And exactly that there's a gap. There's always been a gap between the HPRS as how it was rolled out and the health information system, which the province has gone far ahead in terms of rolling it out. And where we are now, the CROs, I think, provided a roadmap in our presentation to demonstrate that from a health information system, we've gone a long way in terms of bringing facilities, hospitals, 33 CHCs, and what we've been able to achieve. However, at the interoperability level of moving, which is a national prescribed format of the HPRS, it's something that we're working on, and we've provided a roadmap in terms of really what needs to happen. And really what needs to happen is that the clinics and the CHCs that are remaining outside the HIS be integrated and brought on board, and that linkage between the two, and ensuring that there is connectivity to link the two will really then deliver us in as far as the comprehensive HPRS. And I think there's a question also that was raised by a member around our audit findings and how the lack of information, and it is exactly that we have been rolling out health information systems while to some extent at the core of the AG issues, because as you know, that AG takes mandate centrally from national. They've been testing us on HPRS, which we are the first one to concede that we have not rolled that out comprehensively, and is not at the maturity level that is required. But on other elements of the HIS,
health information systems. I think we've been able to demonstrate, I think even when the members were in the province, they will have seen some semblance of that being rolled out and how it's demonstrated. It is at the CHC and the clinic level, where the HPRS is slightly immature that we need to do. The other last question maybe from my side before I allow the rest of my colleagues to assist is the reference to the 4.8 billion unpaid invoices, and I think it needs to be just to contextualize that is a total accrual value as an end of the financial year, and in there are a whole lot of factors that needs to be factored and being considered. Some are invoices that are disputed, some are the projects that will have been rolled over, some are issues that are subject of ongoing SIU investigations. So when the figure is punted as 4.8, there are details that needs to, and when you unpack the figure is not as articulated as such. There are other elements that contributes to the total figure, which including some of the grants that will have been approved for rollover, which means then that money is being made available to continue to either roll out the LINAC projects and other capital infrastructure projects that we are rolling it out as a province. I think the issue about the percentage of the population registered is something that I think I will leave to the rest of colleagues in health information, Chair, through you. And maybe let me pause here and ask the CIO and then the CFO to just make some additional comments before the meeting wraps up.
No, thank you so much, HOD. Maybe just in addition, it's Monturi Butan, acting CFO Gauteng Health. In addition, there was a question as to how much has been paid to date in terms of that value of 4.8. We have at this stage processed and paid 2.3 billion of that value, subject again to verification and validation of some of the invoices that are sitting in that accrual value. The breakdown in terms of what has been spent in terms of hardware and software from 2019, overall we spent 142 million. The breakdown is that 29.7 million was spent on the hardware and then 113 on the software. For 2020-21, a total of 94 million was spent, breaking it down into 31.6 million of the hardware and 62.8 million of the software. For 2021-22, we spent 138.9 million, of which 31.2 million was for the hardware and 107.7 million was for the software. And then for 22-23, we spent 49.3 million, of which 46 million was for hardware, and then the 3 million was for the software. Thank you, Chair.
Okay, good afternoon, good morning again, Chair. So on the issues that have been raised around the HIS itself, I think HOD has actually covered quite extensively. As the province, in terms of the digitization, we are quite very advanced as far as the HIS is concerned. That project is it's almost at the tail end. And again, to drive the innovation around the digitization, we've already started a project around the scanning. We've already completed one of our biggest hospital. So now we are in the second phase to complete the rest of the 36 hospital. Then focusing on the issue around the PHCs, our target now is to invest really on the PHC level, obviously starting to drive the issue around the network connectivity at the PHC level, which is the clinics. That process is already commenced. We've got a plan around that so that we can make sure that all the systems, particularly those strategic ones from the national, including the the HPRS, will be driven at that level. So that project, we're really hoping that we should be able to conclude as soon as possible so that we can start to see the improvement around the HPRS. Under the issue of the participation on the HPRS, Chair, I must indicate that perhaps I'm not aware of the province refusing to participate in any initiatives around the HPRS itself. I will leave it there, Chair. Thanks very much.
Thanks, Chair. Chair, I think all the other issues that the committee members have raised, I've noted them. And I want to apologize in areas where we're unable to give you some information that is needed, especially the one that the letter was written to Dr. Mankopane, because it was not in my office. It went straight to the department, not even to the HOD nor myself, which I think that was a miscommunication that I want to professionally apologize to the committee members, because it's unlike we're undermining yourselves. But from now onwards, Chair, I will appeal that when there's something that involves my office and the HOD, at least the information can be sent to us. Jocelyn is going to forward to the committee members all our documents so that we're able to address those things that members are needed, especially that research, because that was critical and important. So we're not undermining you, Chair. So that's my take, Chair. Other issues, Chair, if the one members wants to do follow up on the questions, they will definitely do that so that we can answer that and submit the questions if we didn't answer them properly to yourselves. Thanks, Chair.
Thank you very much, MEC, and the team from the Provincial Department of Health in Gauteng. To the MECs as well as the teams, according to me, there are some few lists that the committee members requested. Is the list of the number of healthcare users that are registered on the different HPRS systems in the different provincial departments. Then a list of facilities and gaps at the different facilities. And then the estimate cost and timeline to bring all health facilities up to date regarding the HPRS. And then to Northwest, a report on the Northwest officials that are in court at the moment. And I will, like the MEC of Gauteng indicated, I just want to request the different departments to please partake in the different research projects of the NCOP when the officials of the NCOP needed some information regarding different projects. So I just want to thank the MECs and their team for availing yourselves and for giving us the presentations as well as the responses. We really, as the committee, appreciate it. Thank you very much. And I will now release the teams from the different provinces. Thank you very much.
Maybe, Chair, before you release that.
Thank you very much, Chair.
Before you leave, MEC, just Honorable Mokwele wants to indicate something.
No, Chairperson, no, my apology, because I raised my hand before I can see that you are just about to release them. Chair, maybe with the statement that you've indicated, especially with the outstanding information that we need from different provinces or from those provinces that presented before us, I suggest that maybe before they leave, because I suspect that the information is readily available, they are not going to dig the information. If they can say within 7 days, we get that information in your office, so that as the select committee in our meeting, we are able to entertain them, so that they mustn't leave the meeting just by saying that we say we are requesting. So I'm suggesting to the meeting through you, Chair, to say that if they can say within 7 days they provide us with that outstanding information. I thank you and my apology for that.
Thank you very much, Honorable Mokwele, and thank you very much for reminding me. So to the departments and the MECs, if we can get that information in 7 days. Thank you very much.
Thank you.
You are now released. Thank you very much, MEC.
Thank you. Thank you.
So, honorable members, we are left with the minutes of 11 June Can I get a mover for the adoption? I see Honorable Adriaanse.
Yes,
open
I adopted. I went through it, so yes.
Thank you very much, Honorable Adriaanse. Honorable Fanny.
Thank you, Chair. I'm seconding the adoption.
Thank you very much, honorable members. Honorable members, thank you for your time and as well as our support staff. Thank you very much. This meeting stands adjourned.
Thank you.
Bye.
Members, thank you, colleagues. Goodbye.
Thank you, Chairperson.